Hello. Good evening, folks. Happy Sabbath. Thank you for coming together this evening. We have a very special person presenting to us this topic of preventing colorectal cancer. This is Dr. Amar Podugu. He's a good friend of mine. We've met in Canton several years ago. He's actually a student of Dr. Meena Rajan and Dr. Melvin Rajan, because he was a resident with them for a while. And he was a resident at Altman Hospital for 3 years, went to Cleveland Clinic to do his fellowship in gastroenterology. He's been practicing here for over 7 years in Canton area. And he's been such a pleasure to know in our area. I think my mom goes to see him, and I've referred several of my friends to see him. Not only is he a very, very well-rounded gastroenterologist, he's a very pleasant person to talk to, and he takes his time. So always enjoyed our conversations together. And he's been kind enough to present this very important, timely topic. Unfortunately, these days, colon cancer is becoming even more prevalent, and it's a vital piece of our knowledge to know what will cause it, what will prevent it, and what you have to do if something like this is evolving within yourselves. So I'd like to thank Dr. Rajan for putting this together, and thank all of you for being here this evening. And Dr. Podugu will give us our talk for this evening. Welcome.
Thank you, sir.
Yeah.
Well, thanks, Sunny, for such a kind introduction and welcome. And thanks, everyone, for your attention. And thanks, Dr. Rajan, for this opportunity. So without much delay, we'll go ahead and start the presentation for today. This is about understanding and preventing colorectal cancer. The hope is by the end of this presentation, hopefully we are making some impact on colon cancer, understanding colon cancer, and what are the screening tests out there that are available that you can choose to go ahead and get screened. So this is a brief overview of my presentation. We'll talk about the burden of colorectal cancer, both in our community and in the country. And then we'll be talking about that, colon cancer is very much preventable. If we do what we have to, this is a preventable condition, and we all can prevent it. And what are the risk factors that increases the risk for developing colon cancer? And what are the screening tests out there, and who qualifies for screening colonoscopy or other colon cancer screening tests? So the colon cancer is number 2 cause for cancer-related deaths. It follows lung cancer. But the good news is this is preventable. This is probably the 3rd most cancer, both in men and women, reported in our country. Approximately 150,000 plus cases are diagnosed every year. And of these 50,000 plus cases, unfortunately, they succumb to colon cancer and die from it. Approximately the lifetime risk for developing colon cancer among men is 1 in 25. Sorry, it's 1 in 23, and in women it's about 1 in 25. That is about 5% risk. And the recent trend shows that people born in 1990, that is younger crowd, younger people, are unfortunately at higher risk for developing colorectal cancer than compared to people who were born in 1950s. And the reasons are still not certain, but we are suspecting this could be lifestyle changes or the diet that we eat. So there is a recent increase in colorectal cancer among younger people. That led to the change where 45 is our new 50. Everyone needs to start screening for colon cancer starting at age 45. Previously, it used to be 50, and we have changed this approximately 4 or 5 years ago. And now we all need to understand 45 is the new 50. So colorectal cancer, this is a preventable colon cancer. This is a preventable cancer. And why do I say that? Because lot of times you come across certain screening tests out there which helps in detecting early cancer, like prostate cancer, breast cancer. You're able to detect cancer at a very early stage, but not prevent it. Colon cancer is probably one of the unique cancers out there. If we do screening colonoscopy, we are able to prevent it from happening. So how do we prevent it, and why is this colorectal cancer screening important? The way we can prevent it is because a lot of times during colonoscopy, when we do screening colonoscopy, we come across small little growths called polyps. And these polyps, if left alone in the colon, they turn into cancer. By removing these polyps, we go ahead and make a difference and prevent the development of colorectal cancer. So polyp removal helps in preventing colon cancer. And if you look at this slide, this is a basic slide showing how the small little growths here, as you see these small little growths here, they are the polyps. They're usually benign. And these are the polyps that are addressed during colonoscopy. Over time, the small polyps, they gather together and then they cause some changes within the cells. In scientific word is called dysplasia. And if this dysplasia left unchecked, it can progress further into colon cancer. And during colonoscopy, we address the first 3 stages or polyps, and some of these polyps can have cancer, and we are able to remove these polyps. 99% of the times, if there is a cancer in the polyp and we are able to remove it with adequate margin, that itself is a treatment. You don't have to go through surgery. But if the cancer within the polyp invades the deeper layers of the colon, or it spreads through all layers of the colon, unfortunately, that's when you need to have surgery. The aim is at least you diagnose here at this stage. That's a very early cancer. Why is it important to diagnose at an early stage? The reason is early cancer has a significant implication on survival. The earlier you diagnose, the better the survival rate. And colonoscopy is probably the only test where we are able to prevent it by identifying the polyps at this stage and removing it. And this is a colonoscopic view of what I have said. The polyps here, as you see, they're small little growths, and it takes 10 to 15 years to develop into colon cancer. Some polyps which are large may take much quicker, but this is usually the progression of the polyps to colon cancer. And in scientific language, we call it adenoma-carcinoma sequence. So colon polyps, they can come in different sizes, shapes, and the most important part is not all polyps turn into cancer, but all cancers usually come from polyps. So as I said, they come in different sizes and shapes. And as a gastroenterologist, when I'm trying to do the screening colonoscopy, 99% of the times I'm able to remove the polyp. However, when you come across big polyps like this, sometimes it becomes difficult for us to remove the polyp. And usually these are the patients who are sent out to seek additional help from a tertiary center, or we send these patients out to a surgeon to get these polyps out. And sometimes they're in a difficult location. So these are some polyps, just showing you the pictures where it comes in different sizes, shapes, and we ultimately remove them, and that's how we prevent the development of colon cancer. So who are at risk for having colorectal cancer? Almost every one of us are at risk for developing colorectal cancer. As I said earlier, the risk is approximately 5%. So 1 in 23 for men and 1 in 25 for women. And as I said, there is more increase in colorectal cancer among younger people than the older ones in the recent times. But broadly, to offer screening colonoscopy, we categorize them into average risk and high risk. Average risk is anyone who most of us actually fall under average risk. So let me define what high risk is. So high risk, is any patient who has a first-degree relative who is affected with colon cancer, and the first-degree relative is around 60 years of age or less, that's a very significant family history. And if you have two first-degree relatives, irrespective of the age, that itself is again a significant family history. So that's one of the categories for high risk. Or if you have a personal history of colon cancer or personal history of colon polyps, that again is a high risk. Or if you have any genetic conditions that make you more susceptible to develop colon cancer, like Lynch syndrome, that's again a high risk. And if you have inflammatory bowel disease, like ulcerative colitis, Crohn's colitis, because of inflammation in the colon, these patients are at higher risk for developing colon cancer. If the answer is no for any of these four, then you are average risk. If the answer is yes, then you belong to high risk. And any patient who is under high risk, we do not offer any other colon cancer screening test other than screening colonoscopy. What are the other risks that can further increase your risk for developing colon cancer? We can categorize them as modifiable risk factors and non-modifiable risk factors. Meaning, non-modifiable are the things where unfortunately you can't make any change. That is age, race, genetics. Those are the three things that usually come under non-modifiable risk factors. And although I say advancing age, the recent trend actually shows the younger people are more at risk. And then the modifiable risk factors that we tend to change, that can be changed and it can have an impact on your health, include making sure you eat more high fiber, less red meat, trying to make sure your diabetes is under good control or avoiding diabetes altogether, avoiding obesity, and increased physical activity. All these help in improving or decreasing your risk for developing colon cancer. And the other most important modifiable risk factor that I did not mention here is making sure we are up to date with screening colonoscopies or screening for colon cancer, any test. And if you avoid that, unfortunately, that increases your risk for developing colon cancer. So what are the symptoms? What symptoms do you present with if you have colon cancer? So for the most part, there are no symptoms. You have no symptoms, and that's why it's important. Pain is an important thing. Pain makes us grabs our attention and make sure that we are reporting it to our healthcare providers. Most of the times the cancers are painless, and that's why it's so important to get screened, because by the time you have symptoms, it's a little too late in the game. So should you wait until you have symptoms to get screened? The answer is no. But let's say you undergo screening colonoscopy and you do well, and you do develop any of these symptoms, and some of the symptoms that are related to colon cancer include change in the shape of your bowel movements, or if you're losing weight, or if you're noticing any blood when you have a bowel movement, or unintentional weight loss, and any signs like if you're seeing your primary care provider and they see a new onset anemia or iron deficiency, your low hemoglobin, that all can point towards possibility of colon cancer. But again, you do not wait for these symptoms to occur to get screened. So get screened, don't wait for the symptoms. So screening and colorectal cancer. So these are the various tests that are available for colorectal cancer screening. They can be broadly categorized into stool tests, and the other one is the test that can visualize the colon. So the stool test, the most important one with great sensitivity is the FIT test. The FIT test is done every year, and it tries to identify a human protein or globulin in the blood. And so it is more specific than the test that we used to do before called FOBT test. And the one which has become more popular in the recent years is a Cologuard test, or the scientific name is multi-targeted DNA test. And this test basically looks at the DNA that is shed from the tumor cells, and it detects the presence of tumors or cancers. And among the visualized tests, the tests that we use to visualize the colon, colonoscopy is number one, and this is the most commonly used test here in USA. And the other options are flexible sigmoidoscopy and CT colonography. CT colonography is an imaging test where you still need to do the bowel prep, clean your colon, and you undergo CAT scan, and it can identify polyps. And then if it does identify polyps, you have to go ahead and undergo colonoscopy. In the same way, you can do something called flexible sigmoidoscopy. It is a shorter scope. It doesn't examine the entire colon and examines only a very small segment of the colon, which is about 1/3 of the colon. The only advantage of flexible sigmoidoscopy over colonoscopy is, this can be done with no anesthesia. But again, because it's being done without anesthesia, sometimes patients may have a little bit of intolerance, and then, it can limit the exam. All these tests, other than colonoscopy, if it is positive, it should be followed up with a colonoscopy. The colonoscopy is the only test where it's a one test. You get it done, and if it is clear, and it has probably the most mileage on it, when I say mileage, if it is normal, you don't have to repeat this for the next 10 years. So that's the only advantage with colonoscopy. You do it once, and it's taken care of. You have a good bowel prep, no polyps. It's good for next 10 years if you're an average risk. Any other test, like FIT and FOBT test, if it is positive, we need to follow up with a colonoscopy. And the same holds true for Cologuard test or flexible sigmoidoscopy or virtual colonoscopy. And if the FOBT or FIT is negative, we have to repeat it again in 1 year. And if the Cologuard test is negative, we have to repeat it in 3 years. And the flexible sigmoidoscopy and CT colonography is 5 years if it is negative. So that's the difference between one-step versus two-step screening colorectal cancer screening. So one step is screening colonoscopy. Any other test that you use, it's going to be two-step process. If it is positive, it should be followed up with a colonoscopy. Oftentimes, I come across patients where they assume it could be false positive. That's a wrong assumption. We have to assume that it's colon cancer unless proven otherwise, and we need to follow up with colonoscopy. So it's the same thing that we spoke about different screening strategies and two-step. And American College of Gastroenterology, in short, ACG, recommends the first line is either proceeding with screening colonoscopy or FIT test. That's the recommendation. For some reason, you are unable to undergo these testing, then you have to discuss about alternatives, which are like Cologuard tests or using flexible sigmoidoscopy or CT colonography. So as outlined here, again, the first two tests that ACG recommends is colonoscopy and a FIT test. And the others are alternatives. So screening for patients with strong family history, that's a subset of high-risk patients. And again, these high-risk patients, they have a tailored approach. It's ideal to have a discussion with the PCP or the GI provider. But in short, if someone has colon cancer among immediate family members who are 60 or under, we recommend starting colonoscopy screening at age 40. And even if you have, any family members have advanced adenoma, so advanced adenoma is a polyp that's either more than 1 centimeter, or you have advanced pathology like tubulovillous adenoma, we make a recommendation that these patients should start screening at age 40, even if you have strong family history. And the other conditions that we do earlier screening is genetic conditions like FAP and Lynch syndrome. And for patients with Crohn's colitis or ulcerative colitis, After 8 years of UC or Crohn's, we start them for screening, and it's usually done every 1 to 2 years. And as we discussed before, among all the screening tests, obviously the screening colonoscopy has advantage of just not detecting early cancer, but also to prevent colorectal cancer by removing the polyps at a very early stage. So you're addressing the cancer even before it starts. This slide is kind of important to show how all these screening tests do in comparison with each other. And recently, there's a blood test that's approved for colon cancer screening. But again, the blood test has its own disadvantages. And here, the big bar that's showing, that's the blood test that was recently approved. And if you look at the bar right here, this is no screening. And if you look at this axis, it just shows if you do not undergo screening, there's approximately 7,000 to 8,000 cases per 100,000. You can be diagnosed with colon cancer, approximately 7 to 8,000 among 100,000 cases. And the blood test does show that it improves, it's better than no screening at all. But this blue bar is a colonoscopy, and it is so effective in reducing the incidence of colorectal cancer, making it less than 2,000 cases. And here is the other stool test, which is also very good. It's decent. But the blood test, because of the convenience, it's approved. And our target is to get at least 80% of population to get colon cancer screening. That's our target. And the national average is around 65 to 70%. And we are trying to improve the colon cancer screening, and we are hoping this blood test would make a difference. But again, convenience doesn't necessarily mean it's a good test. As you see, colonoscopy and stool test is still probably the best test out there for colon cancer screening than the blood test alone. And if you choose not to do the stool test or colonoscopy, again, probably blood test is better than not getting screened at all. So yeah, that basically shows that the blood test is there. It is better than no screening, but it's inferior to other screening tests out there. So in the next few slides, I'm going to talk about colonoscopy in general. And this is just a slide showing the anatomy where the colon is located. This is the last part of our digestive tract. And the colon can be further categorized or divided into cecum, colon, rectum, and anus. And the colon can further be categorized depending upon the location as ascending colon, transverse colon, descending, and sigmoid colon. So during colonoscopy, we'll be inserting a flexible scope with a camera and a light source attached to the end of the scope. And once you're under anesthesia, once you do the bowel prep, cleaning, and you come here, we make you lay down on the left lateral position, left side, and then we insert the scope once you're anesthetized, you're asleep. You'll remember this as a good nap. And the procedure itself takes around 30 to 60 minutes to get done. And again, 30 to 60 minutes if you're taking care of multiple polyps. And if there are no polyps at all, sometimes we are done by 20, 25 minutes. This is the procedure time. And the pre-op, post-op, from the time you get out of the car and getting back into the car, you plan on spending at least 1.5 to 2 hours time. And we insert the scope through the rectum, and we advance it all the way to the end of the colon. And once we get to the end of the colon, that is the cecum, we start examining the colon and withdrawing the scope. What is our aim? And while examining, we insufflate the colon. Colon is a collapsed organ, so we want it to expand. So we introduce some air or CO2 to expand the colon, and we'll be looking for these small little growths called polyps. And our aim is to get the polyp out. And this is how we remove the polyp. And the common tool we have few different tools that we use to remove the polyp. The common tool that we use is a snare. and the snare goes around the polyp. Depending upon how big the polyp is, sometimes we may use current to go ahead and cut that polyp out, and it's called hot snare or heat coagulation therapy. Remove the polyp, and the specimen is collected. And the collected specimen is sent out for pathology. And that's where the pathologist tests it under the microscope and gives us additional valuable information to know what kind of polyp we are dealing with. And depending upon the size, the pathology, the number of polyps, and the adequacy of bowel prep, how clean your colon is at the time of colonoscopy, we determine how often the person should come back for a colonoscopy. On the day of the procedure, you plan on not making any major decisions. Number one is making sure that you have someone to give you a ride. You're not allowed to drive because you will be under anesthesia. And then, again, we don't want you to operate any machinery. What are the complications that can come from colonoscopy? I want to say the complication rate is extremely low. But if you do develop complications, some of the complications that can happen is bleeding. As you saw earlier, when we remove a polyp, there is an ulcer right here. So this is an ulcer we are creating. So the ulcer can sometimes bleed. And the risk of bleeding is up to 2 or 3 weeks after undergoing polypectomy. So sometimes I ask my patients not to plan on going anywhere international or on flight very next day after the procedure because there's a risk for bleeding. If they're in town, we can go ahead and take care of the complication. So bleeding is one important factor or one important complication that can happen from colonoscopy. And the other important complication is perforation, which is accidentally poking a hole through the colon. And that can give fevers and incredible abdominal pain. But again, they don't happen usually. So what are the complication rates? From anesthesia, you can have cardiopulmonary risk, and that is less than 1%. And usually the other complications are about 0.03 to 0.08. That is about 4 to 8 patients in 10,000 patients that get screened can have a complication. I was trying to look at the data. I just wanted to show you the perspective. It's probably the odds of having a fatal motor vehicle accident is probably higher than getting a complication from colonoscopy. I don't know how accurate this data is about motor vehicle accident because this is ChatGPT telling me. But having said that, just to get an idea, the odds are extremely low. If you're worried about complication from colonoscopy, we all should be worried about not driving the vehicle. The day of the procedure is important, and so is the day before the procedure. In fact, in my opinion, the day before the procedure is probably the most important part for screening colonoscopy. You got to drink the prep. You got to be on clear liquid diet. And why is it so important to follow the instructions? The good bowel prep makes an immense impact. If the prep is not good, you look at this polyp, this cannot be seen. And you can miss polyps. And we can't make the recommendations. 10 years is good only if your colon is clean. Unfortunately, if the colon is not clean and we fail to follow the instructions to do the bowel prep, we may have to bring our patients sooner. And the sooner is about 6 months or 1 year. And we don't want to do this. We want to do it once and do it right. Why is it difficult to do the prep right? You can't eat. You got to be on clear liquids the day before. And you have to drink multiple ounces of the prep. And we do offer some tips to make it easy. But yeah, it can be a little painful. But as a famous saying goes, no pain, no gain. So I think if you do it right, and again, as I said, if everything clear, you don't have to worry about it for 1 year, 10 years. And the bowel prep that we are using right now is a split prep where you have to do half the gallon the day before and half the gallon on the day of the procedure. And we want you to maintain strict NPO status. That means you can't eat or drink 2 to 3 hours before you come for the procedure. And the reason is, when we give you anesthesia, we don't want the contents in the stomach to come into the lungs, and that's called aspiration. So strict NPO status for 2 to 3 hours before the procedure time. In addition, if you're on any blood thinners, diabetic medications, that needs to be regulated, and especially blood thinners. We need to get the blessings from the cardiologist, make sure it's okay, it's safe to go ahead and hold these blood thinners prior to the colonoscopy. And it's important to hold these before the procedure and do what's needed. And that's what is usually addressed in the office visit before we do the colonoscopy. So the complete bowel prep and a clean bowel prep is the key to make the right recommendations. So bottom line, I don't want anyone of us to give any excuses to undergo colonoscopy or colon cancer screening. You just can't say, I feel fine, no need to do it. No, this is the colon cancer screening are for healthy people to make sure they do fine moving forward. And again, it's the same thing. I'm healthy, I don't need to get screened. That's not true. All healthy individuals need to get screened. Well, I don't have any family members with colon cancer. Well, you don't want to be the first one in your family. Your family members are probably up to date with screening colonoscopies or screening for colon cancer. So you don't want to be the first one. I have no risk factors, and this is what I was saying. The single important risk factor or modifiable risk factor is not getting your colon cancer screening or not being up to date on colon cancer screening. So that's one important modifiable risk factor. Only men get colon cancer. That's not true. Both men and women are equally at risk for developing colon cancer. So in summary, I want you guys to I want every one of you to understand 45 is our new 50. There is more increase in colorectal cancer among younger people for reasons unknown. There are quite a few tests out there which can be used for colon cancer screening, but ACG, American College of Gastroenterology, recommends either proceeding with screening colonoscopy every 10 years or doing a FIT test every year. And if you belong to a special category where you're high risk, we definitely do not recommend any other stool-based testing. We highly recommend doing and proceeding with screening colonoscopy. And the screening interval is determined based on the bowel prep and the number of polyps that have been identified, the pathology. And based on these, we determine how often we should bring you back for colonoscopy or colon cancer screening. Last but not the least, among all the tests out there, the best test is the one that gets done. So it's important to make sure you pick any one, but make sure you get it done. And if you have an option to pick one that's appropriate for you, as I showed you earlier, there are a few different tests, and some of them are better than the others. So the best test, again, is the one that gets it. Yeah, the best test is the one that gets done. Well, thank you so much for your attention. And I'm happy to take any questions.
Do you have any information on milk being a contributing factor to colon cancer?
Say that again, I'm sorry.
Do you have any information on milk being a contributing factor to colon cancer, like the amount of milk that you drink affects?
No.
Because I had attended a thing a while back that said that.
Yeah, milk is not one of the known risk factors to say that it can increase your risk for colorectal cancer. The one major risk factor is red meat.
What about lactose intolerance?
Oh, milk can give you lactose intolerance, and lactose intolerance will make you miserable, but it won't kill you.
Any other questions?
I was just wondering, I know you talked about the screening being the most effective modifiable risk factor. Can you tell us a little bit more? And you said red meat is a big one. So what about, what is the effect of being sedentary? And I saw MD up there, I can't remember what it stood for. And some of these other risk factors, alcohol, tobacco, and whatnot. How do they affect the colon?
I think the colon cancer, just like anything else, the most important factors that are associated is red meat, as I said, and then trying to increase the high fiber or any different vegetables and the colors, different colors of the vegetables, as much as you can incorporate in the diet. It has an antioxidant property, and that will help you. And then the most important part is physical activity. Sedentary lifestyle has been associated with a lot of ailments, so is associated with colon cancer. So physical activity is kind of important to make sure to reduce the risk. But again, despite all these, as I said, when I say known genetic conditions, there are only few genetic conditions that we are aware. There's a lot we don't know. So a lot of it could be genes, and it could be family history, and that's very important to work on. And the screening test is a way to go ahead and figure out, are you having issues? And if you do have issues, we got to take care of it. So even in the slides that I mentioned about genetic conditions, there are very few that we are aware of. There's a lot we don't know, and it's still in the process. So I think that's why it's important to go ahead and get screened, because a lot of things are things which are beyond our control, and I don't think, even despite someone who is eating high fiber, despite someone who is doing everything, physical activity, if they have an underlying genetic issue and that increases their risk for developing colon cancer, no matter what they do, the screening test is what's going to save them. I hope, does it answer your question?
Yeah, I think that's all.
Okay, good.
Hello.
Yeah.
Sorry for showing up late. You might have already answered this, but what are the main signs and symptoms of showing that you might have like colon cancer or anything like that?
Yeah, so most of the times when you have colon cancer, they don't have any symptoms. There are no symptoms at all. And by the time you develop symptoms, it could be a little late in the game. So some of the signs and symptoms are unintentional weight loss, if you're noticing any blood in the bowel movement, if you're noticing any change in the shape and the size of bowel movement, or if you have any signs on your labs like anemia, iron deficiency, this could be a very early sign for colon cancer. And again, as I said, sometimes by the time the signs and symptoms develop, it could be a little late in the game, and the cancer can spread elsewhere.
So, Amar, one quick question from me.
Yeah.
If somebody has colon cancer, a family member that was diagnosed very early with colon cancer, below age 50, 45, what is the screening for the family on those patients?
Yeah, so if you have a first-degree relative diagnosed at age 55, then the colonoscopy should start at age 40. But let's say if you have a family member who was affected with colon cancer at age 40, then we should start the colonoscopy for the immediate family members 10 years from the age of 10 years before. Like for someone who is 40 years and diagnosed with colon cancer, we recommend starting colonoscopy for screening at age 30.
Besides red meat and cigarettes and alcohol, what are good foods and what are bad foods?
Just like anything else, the good food is high fiber and making sure you incorporate more vegetables, fruits. And the bad food, I would say, I don't want to label it as bad food, but again, any processed food is a bad food. Red meat, not generally, I wouldn't say red meat itself is a bad food, but again, limiting and eating those in moderation is probably not a bad idea. I think that's what the good food and bad food would be. Yeah.
So since I was 10 years old, I've had IBS, and so it's been a lifelong thing almost. And so recently, about 4 years ago, I was diagnosed as having SIBO. And so we started eliminating foods that, were causing problems.
Mm-hmm.
And that really helped. Now, just the last couple months, a friend suggested drinking kefir. And
Drinking what again?
what's that?
Drinking what? I'm sorry.
Kefir.
Yeah.
Do you know what that is?
I did not.
It's a high, has good bacteria in it,
Mhm.
and it's kind of like almost like sour milk.
Okay.
Okay. So, I mean, my stomach has been amazingly good since doing that. And so, I don't know, all those things, because I had problems all my life, does that make me a greater candidate for colon cancer?
No, it doesn't make you any higher risk than what the average person is. I think some of your symptoms are coming from irritable bowel syndrome, and irritable bowel syndrome can happen to any one of us. And some people have situational irritable bowel syndrome, and some can suffer from it on a regular basis. But that doesn't elevate your risk for developing colon cancer. Sure.
Is this probiotic help you?
So the probiotics, there is no data. If you look at the data, because, if you want to make a difference at a national level or a global level, you want to make sure that the studies and the results are consistently reproducible. When it comes to probiotics, there is no data to suggest that a vast majority of us will get a benefit. And it could be, and for patients who come and say, hey, I took this probiotics and it's helping me, I tell them that it's okay to continue. There is no data to recommend that. And it's okay to continue because there's no harm. All the studies haven't shown any harm. So it's okay to continue, but again, there is no data or no evidence to support that using probiotics will help or improve the gut health.
So I've taken a lot of probiotics, so nothing has helped me, but the kefir has. So I don't know what it is about that, but that's made an amazing difference.
No, and I totally agree, because there are some patients who have a significant outcome, and when they do have a significant outcome, that's a great thing. But it could be only an individualized or tailored approach. We cannot, because what worked for you may not necessarily work for someone who has similar symptoms, same age, same issues, and same other medical problems. It may or may not help. So those results are unfortunately not reproducible, and the data so far shows just use individualized, tailored treatment as far as probiotics are concerned. But I can't make a generalized statement saying that this will help, and I definitely can't encourage people to spend money to get these probiotics, because we don't know if it will make a difference. Go ahead, Sonny.
Quick question. You mentioned that there's a more earlier presentation of cancer compared to in the past. What do you think are like some of the biggest reasons why we're seeing younger people developing or being diagnosed with colon cancer compared to in the past?
Yeah, I think it's mostly the means of what we are eating. I think we are eating a lot of processed food, and there is more access to processed food in this current day and age as opposed to what it was a few decades ago. And I think that is one single, again, it's complicated to answer because we don't know, but that's what people or the data is suggesting. It could be coming from lifestyle changes. And a lot of us are probably doing desk job and we are not as active. And the physical inactivity is, again, probably a big risk factor for younger people to develop more cancers.
I just want to follow up on that and just ask, what are your suggestions for us in outreach to our children, grandchildren, whatnot, to help them? Just on this topic of colorectal cancer, what are your suggestions for outreach to the younger generation?
The one single suggestion would be to keep moving. So I think a lot of my patients, in fact, some of my 90-year-old patients who look really good, that's the advice that they give. Keep moving. And it has shown significant outcomes. And I think that's what we need to do. Do not encourage video games. Hopefully they're out and playing, and physical activity and eating right. And again, obviously, as I said, it comes down to avoiding fast food like KFC, McDonald's. Hopefully we should avoid those food and try to eat. It takes more effort and sometimes probably more money to get good food like salads and eggs. But unfortunately, those are the things that we need to do and avoid fast food.
I know we're talking about colon cancer, but how about diverticulosis? How do you prevent that, and will that lead to cancer?
Diverticulosis doesn't lead to colon cancer, but it can lead to diverticulitis or diverticular bleeding, where these pockets can bleed. The way to prevent it, again, there is some genetic component to it, and the modifiable risk factors, again, it comes to high fiber. A lot of us are less on fiber, and avoiding constipation is another important risk factor to modify, and that will help prevent diverticulosis, or at least complications coming from diverticulosis. No, complication.
No, is eating nuts contraindication?
No, it used to be a myth where we believed that nuts will cause increased risk for diverticulitis, but the data doesn't show. It doesn't prove that nuts or corn, it increases your risk for diverticulitis.
Thank you.
Sure.
Any other questions? Well, if there is no more questions, thank you, Dr. Podugu, for coming to our
Thank
church.
Thank you. Thanks, everyone, for your attention.
We appreciate that. Thank you again. If you have any other questions, Dr. Podugu is a local GI doctor. You can always go and see him in his office. So we're kind of wrapping up for the year from our health ministry talks. We're going to take November and December off, but we're going to start back in January. So we'll see you all again in January for our next talk. And we're going to start out in January talking about fall and fall precaution. And then I just tagged on to the young man back there. He's a cardiologist. He just said he's going to come and give us a health talk. So we're happy he came to visit us today. All right, thank you, everyone, and have a good evening.